Okay, good morning, everyone, and welcome to the training on risk assessment delivered by my friend and colleague, Dr. Habib Nairamadi. It is my pleasure to introduce him to you today. Dr. Nairamadi received his PhD from the University of Pennsylvania in 1990. He began working with the state of New Jersey as a staff psychologist at North Princeton Developmental Center, later at New Lisbon Developmental Center, and finally at Anne Klein Forensic Center. He received training for assessment and treatment of sex offenders and conducting risk assessments from doctors Barbara Schwartz, Robert Hare, Stephen Hart, and Vivienne DeVogel. He developed a sex offender treatment program for the civilly committed developmentally disabled patients at the Moderate Security Unit in New Lisbon Developmental Center. He also developed a sex offenders assessment and treatment program at Anne Klein Forensic Center for civilly committed patients. He has been teaching courses related to violence risk assessment for the state psychologists, psychology and psychiatric interns, and social workers since 2000. He has presented multiple topics related to violence and ethical issues around assessment and treatment of the violent and sexually violent offenders in national seminars and conferences. His last position was as Director of Psychology at Anne Klein Forensic Center, from which he retired in 2021. So it gives me great pleasure to turn this over to Dr. Habib Nairamadi. Dr. Nairamadi, you're on mute. You're still on mute. Unfortunately, you're still on mute. Are you able to click your microphone? There you go.
Can you hear me now?
Yes, perfectly.
Okay. Well, let me just go back to. I haven't been working with this Meet Microsoft for some times, and that's why I'm so lost like here. Bear with me, please. Let me. Okay. Am I on?
Yes, you are on and your slides are on.
Okay, great. All right, greetings everybody, and thank you, Dr. Waldron, for the kind introduction. You are doing an excellent job of running this program, and I guess on behalf of the beneficiaries of this bi-monthly training sessions, I can say that we are all so very lucky to have you in charge of this program, working so hard year after year, as long as I remember, for so many years. About today's program and the business of risk assessment, well, this is such a big area that my only hope is that during the 2 days of presentation, introduce you to some very basic concepts related to risk assessment, and also some of the most used risk assessment instruments that are being utilized in mental health and the justice system and in our profession. I must say that if you have not been exposed to the materials that are being discussed today, this presentation by no means can make you an expert in this field. This is just the beginning. During today and the next session, which is going to be 2 weeks from today, we will review the scoring and interpretation of, I hope, at least 5 instruments that you need to know about it. I have tried to gather and include as many information as I could in my slideshow. So if you print it, you can have this information in your hand. It's perhaps 90 plus a slideshow, but some of these instruments require several days of training, anywhere between 2 to 10 days of training for each. So imagine 5 of them in 2 days is gonna be kind of rush. I reiterate that you need to further your knowledge before using any of these instruments. This is a journey of many miles that we are taking. The first step today. So let's start. By the way, if you have any question, please hold on to your question either at the end of the program, or you have my email in the very first slide. You can send me your questions. I'll be more than happy to respond to you. All right, so these are what we are going to review today. Basically, some definitions of the terms that we are using. Some of the definitions might be different than the one that we are using in a common conversation. These are more technical definitions. Definition of violence, of risk assessment, type of risk assessment, and so forth, so on. Let's say about violence, and this is the definition that I want you guys to remember, or to have it handy when you do your assessment. This is the definitions that are in the book and has been presented by the authors of the HCR 20, and this is what we are using. So the violence is actual, attempted, or threatened infliction of bodily harm on another person. So bodily harm here include both physical and serious psychological harm. That these bodily harm, this psychological harm, substantially interferes with the health and the well-being of the person which is subject to this threat. Now, psychological harm includes fear of physical injury and other emotional, mental, or cognitive consequences of the act in question, like stalking. Stalking is a very fearful behavior. If a student, for example, in a college campus realizes that he's being stalked, someone is following her all around, that's very fear-inducing. Kidnapping is another behavior. Confinement is another behavior. By the way, it's not necessarily the outcome of the behavior. It's not the damage to the victim is not the determining factor. What is important is the act itself. I give you an example. If someone has a knife and attacks someone, that is a violent behavior. It doesn't matter whether he will be successful to stab the person or not, but just simply the act of having that knife in his hand and gesturing that is gonna snap the person, that would be good enough to be qualified for our definition. So again, one last time, actual, attempted, or threatened infliction of bodily harm, which includes psychological, on another person. There are some exclusions, there are some exceptions. property damage and animal harm are not considered violence. Now, it might be violent in, this is what I said, that in our definitions sometimes might be different, and these are more technical. But for the purpose of scoring these instruments, especially the HCR20, property damage and animal harm are not considered violence, except that if it is done and it is intended to cause fear or harm or any kind of severe psychological harm to another person. Another example I give you. Let's say someone breaks up with his girlfriend. He's very angry. He wants to punish her. He wants to bark her, to bother her. He goes on and kills the girlfriend's dog. Now, this is violence. Why? Because even though harming animal is not considered a violence in this process, but because it intended to harm the person, now this comes in a category of violence. Also, another exception, act in self-defense or the defense of other people are not violence. Further, sports, military, law enforcement act in war are not considered violence for the purpose of measuring it. Now, I sometimes see sports which two people go inside a cage and beat the hell out of each other, and I see blood all over, and I wonder why it's not violence. To me, this is like legal violence, but again, for the purpose of our work, sport activity, military activity, police, army, these are not considered violence. So we are talking about violence risk assessment. So the second definition would be definition of the risk. A risk is a threat that is incompletely understood, and therefore the occurrence of the threat can be forecast only within uncertainty. So when you do talk about the risk, it's not 100%. It is not totally understood. It is incompletely understood. The term risk is a multifaceted construct which is often used in mental health services to refer to the likelihood and the predicted magnitude of certain type of adverse outcomes. So it is a negative term. I'll give you an example. If you buy a lottery ticket, you never say that, well, I have a ticket and there is a risk of me winning $1 million. You say that I have an opportunity to win $1 million. But you may say that, well, there is a store across the street and the way I see the business is going on, there is a risk of bankruptcy. Now, bankruptcy is a risk, it's not an opportunity. So again, is a negative term for the adverse outcomes and is uncertain. These are the things we need to remember. We go to the next one, assessment. Risk assessment is a process by which the offenders are assessed on several key variables. These key variables have a causal relationship with violence. They are called risk factors that are empirically known to increase the likelihood of committing a violent offense. So when we do risk assessment, we are kind of checking a person's behavior versus several variables which are empirically known to us that they increase the risk. That is called risk assessment. Now, bear in mind that we are assessing the risk. We are not predicting. There's a difference between assessment and prediction. In assessment, it's a state of potential. It may or may not happen. It's a likelihood. It does not need to be materialized to be true. So when you assess someone and you say that this person has a moderate risk for doing something, it doesn't have to be necessarily that behavior occur for you to be correct. Versus once the predicting someone, prediction is a definitive statement about a future behavior that if it doesn't happen, then it's incorrect. So we are not predicting, in other words. We are always assessing. How many types of risk factors? Basically, there are two types of risk factors: the static factors and dynamic factors. The static factors are those factors which are not gonna change. Give you example, gender. Gender is a risk factor. Believe it or not, men are more prone for violence than female. So that has been, again, empirically proven. We have studied, we have done a study, we have seen it, we have observed it. So that's a static. You can't change someone's gender. But with the same, this is the same reason the static factors are not susceptible from treatment. You cannot change someone's gender no matter what kind of rehabilitation you put this person in for the kind of violence that they have done. He's always going to remain man. Even though static factors are more reliable factors for assessment, nonetheless, the negative part of it is just that they're not susceptible from treatment. The second classification, the second class of risk factors are the dynamic or changeable factors. Now, these are less reliable for risk assessment because of the very nature of the being dynamic. But the good thing is they are susceptible to treatment. For example, lack of remorse is a dynamic risk factor. A person who lacks feeling for others is more prone for violence, but we can change that one. We can put this person in, let's say, victim empathy courses or empathy courses and teach him some empathy so he can change. So these are the factors which we can play with for rehabilitation. We are using the risk assessment for various reasons in both mental health and justice system. We are using risk assessment to identify the type, the degree, the intensity of the risk. After finding those factors, then we can develop treatment plan for those issues. We can, develop some rehabilitation program. Basically, we call it risk management. So we assess the risk first. We evaluate the intensity and the duration and all this kind of stuff, and then accordingly we develop treatment plan or management plan for this risk. How to control this risk. Also, one of the best application which I have observed myself is that once you're familiar with these instruments, utilizing a unified approach that enhances the ease of communication. Let me give an example. You may want to send someone to your colleague for some sort of evaluation, and you tell the person, your colleague, that this guy is an intelligent guy. Well, intelligent guy, maybe the word intelligent gives me an impression that, okay, this guy may be above average person. But when you say that this guy's IQ is 135, then I know much better who am I dealing with. As opposed to when you say this guy's IQ is 85. You see, it's just we come to a unified resource in order to communicate with each other. So if I say to Dr. Waldron, for example, when I was working at Anne Klein, and we used to do that, send our patients to her, I could say that, listen, I'm sending a person to you that I have been treating, and he's a dangerous person. Well, I mean, this is just a warning that he's a dangerous person. But if I give her some numbers based on this instrument that we know, then the whole scenario changes. If I tell her that, Nicole, I'm sending you a person whose HCR20 suggests high risk, he has a let's say a static 99 number of 7, he has a VRAG number of 26, then she knows that she's getting a bad dude, because she knows this number, she knows what these numbers mean. So that is another benefit of the risk assessment, that we are utilizing a unified language and approach in order to communicate with each other. That is much more suitable. And again, the risk assessments are
I'm
used
so
in
sorry,
the...
Manuel. Your camera is on, and I'm not sure if you realize.
No, I do not realize. So do you see the presentation, of course, right? Do you
Yes,
see
Yeah,
it's
the
just
no,
slide?
I'm
somebody had
sorry.
their
Your
Do
camera
you
on
see the
presentation is fine.
slideshow?
I was speaking to someone else.
Oh, you were speaking to
Yeah,
someone
I
else.
can see you clearly. Sorry for the interruption.
Okay, and you don't see me though. You just see the slideshow. Is that true?
I can see you as well as the slides.
Oh, I see.
Yeah, so it's perfect.
But the slideshow is on. Okay. Anyway, so I was saying that the application of risk assessment, we are using the risk assessment in a legal system for committing purpose, for civil commitment. If you want to commit someone civilly, you go to court, and the judge should sign it, and he or she's gonna listen to you, and she wants evidence for committing this person, or for commitment of the SVP. SVP stands for Sexually Violent Predator. It's an act which confines the sexually violent people who are not responding to the treatment. For prison placement, for the level of supervision, for probation eligibility, for conditional release, on and on, they are using these risk assessment instruments. Now, the evolution of assessment procedures and assessment instrument. The first generation of risk assessment was unstructured judgment. It was a clinical opinion, what you used to call. And a person would conduct an interview with the subject, and based on that interview and perhaps reviewing a little bit of history or whatever, he would make up a clinical opinion about this person. This was very basic, very incomplete, and I would say not good. So Then it came to structured decision making. I mean, above and beyond just interviewing the person, what else they could have been done in order to make a more accurate assessment, more court acceptance kind of report. Now, that's where the second generation came up. The second generation was the actuarial, and I know that some of these terms might be new to you guys, but I will go through later on, so we will know what they are going to, what are they, what are the actuarial, what are the other ones. So the actuarial was the second generation. I think it came to market as of perhaps 3.5 decades ago. That was the beginning, and then finally the one that now we are using most is the third generation, which is a structured professional judgment. SPJ is called. Let me just explain a little bit of each to you. The first generation, the clinical opinion. The problem is they are very much dependent on the competence and acuity of the assessor, the person who is conducting it. But if you're dealing with a very well experienced and knowledgeable and research oriented and so forth, so on, professional, then you may get a very good result based on his experience. But again, what about if the person is unexperienced? Is it young? Is it other obstacle on the way? So the clinical opinion has to rely on the competency of the assessor, and that's not good. This is a negative. Now, also historically, they have done very poorly in terms of accuracy. The effect size is 0.52. What does that mean? That means that if you want to assess someone and you just don't know anything, you just flip a coin, you get 50-50 chance to be correct about whether this person is dangerous or not, right? Just flip a coin, 50-50. The clinical opinion effect size was 0.52. Only 2% added to this 50% chance. That is not good, obviously. So that's another negative. If I want to say some positive things about it, maybe it's suitable for make some kind of assessment when you don't have much of a time versus on-the-fly assessment. You know, just read the history, and anyway, that is better than nothing. Other than that, people do not use the clinical opinion anymore. If you go to court as a psychologist to testify for dangerousness of someone, and you just say, Your Honor, I think this guy is, my clinical opinion is that this guy is dangerous, it's not going to be accepted. They need evidence, they need scores, they need a document, and the instrument that we are going to learn about it during these 2 days presentations are the ones that are now being mostly used in court and is accepted. They have established reliability and validity and is acceptable in a court of law. So that's about the first generation. Actuarial or second generation. Okay, actuarial tool makes prediction, even though I said do not use the word predictions, but anyway, this is, I have taken this from the book, so I can't change the wording. They make prediction based on the established relationship between the risk, whatever that risk is, risk of violence, risk of whatever, and several objectively measured variables. The variables that we can measure it. Age, we always know how old is that person. Gender, we know that. Marital status, whether the person is single or married. Criminal record, and you see that these are all static. None of these things change. Yes, you get older, but at the given time, that person age is that person age. So these are the things that until for whatever reason we change them, they don't change automatically. The criminal records of a person is never going to change, no matter how the person changes to become a better person, but the history of the crime, whatever he has, is going to be there. So these are the actuarial, these are the static factors, and they have been proven to be more reliable than the dynamic factors. So again, maybe you have to repeat this definition several times for yourself in order to remember it. An actuarial tool makes prediction based on the established relationship between the risk and the objectively measured variables. And these are being done through years and years of follow-up after release of the offenders. Now, what are the pros and cons of actuarial? As I said before, there is a good evidence of advantage of actuarial for assessing violent recidivism over the other approaches. I do remember when actuarial came to market, we were so happy because now we would conduct the testing and we would get some beautiful, clear responses that how risky is this guy? What is the chance of this person recommit within next 5 years? Or what is the percentage of recidivism in next 10 or 12 years? So we were very much, celebrating this and very much actuarial-oriented clinicians we became. But then later on, we find out that as good as they are, there are problems with this. They are very much sample dependent. When you are scoring an actuarial for a person, you're not scoring necessarily, your conclusion is not necessarily for that person. Your conclusion is a comparison of that person with the population like him. So what you say may or may not happen to this person. What you say is that people like him have reoffended, let me rephrase it, 35% or 50% of people like him have reoffended before. That means that this guy may or may not reoffend, but people like him and his age, with his number of the crime, with his specification, they have recidivized within 10 years, 20% of them they have recidivized. So they are very much, and these have been sampled, normed on the different samples, mostly in North America. I'm talking about VRAC, that we will see what they are. I'm talking about static 99. These are being sampled mostly in North America and in Europe also. But when you are measuring, when you are conducting your test, make sure that you are comparing this person with a right sample, and there are various samples and norms which is offered in the manual that you need to choose the one which is closest to your subject. And then finally came the third generation, which is structured professional judgment. The SPJ approach combines the first two together, combines the objectively based, evidence-based selection of risk factors which are known by actuarial with the subjective professional interpretation of the risk factors that the clinician has observed, such as severity of the problem, the frequency of that risk, the duration of that risk. So we are combining these two together. We are not only relying on our own experience and findings, we are not only relying on the suggestions of the risk factor by actuarial either. We are combining this together. and then based on that, we make a final judgment. It is proven that this is the best approach so far. I don't want to say necessarily it is proven. Some might disagree with me, but this is what I have found, and this is what I observe, that right now in most psychiatric hospitals we are using this structured professional judgment for assessing the risk. Let me tell you very fastly a little bit of the history. Building this instrument has taken years and years of work by many people. That and you will see the names of them here and there frequently if you go into the field of assessment. The three names up there, VRAG-R, Static 99, and HCR20. These are the perhaps the mostly used instruments, and each of them have been developed after, as I said, years, sometimes 15 or 20 years of follow-up of the people, of the criminals and offenders after release. The VRAG was done by Vernon Quincy, Grant Harris, Morney Rice, and Cormier. Unfortunately, Grant Harris passed away in 2014, and Morney Rice passed away in 2016. I have been in touch with Morney Rice. When I was at work, and perhaps we were one of the first group that we started using the new norm after VRAG was revised and became VRAG-R. Also on Static 99, Carl Hanson, Thurnon, and Andrew Harris. These are the, again, people that they invested their lives for developing this. And HCR20, Kevin Douglas, Stephen Hart, Christopher Webster. These are, thanks God, these are all around. By the way, if you go online, you will see their names, and if you search their names and their address, they are all going to be more than happy to respond to your questions the best they can. They're very receptacle to question and very helpful. And they have, each of them have signed for each of these instruments. There are signs, there are sites that you can go on and get lots of information. The one I put it underneath, the publicsafety.gc.ca is for, I believe it's for Static 99. And by the way, most of these have been done in Canada, because, as I said, developing this instrument requires years of after release follow-up of the offenders, and Canadians are all the documents in Canada is under one name, so, or one number. So if you know the person and put the person's name in, or the, let's say, social security or ID number in, all the records shows up. As opposed to the United States, that the records are spread around. We have some records in a county, some records are in township, some records are in states, some on FBI, some in CIA, and they are spread around. So it's very difficult, really, to have reliable numbers or information for doing this kind of job. So we owe it to Canadians, really, for most of these instruments. All right, so now we got to the definitions done. Let's go to the assessment process. And there are some rules that we need to follow. Remember that all the collaborative data is essential for effective evaluation. You have to include every information. Information and knowledge is your wealth. The more informed you are, the better assessment you'll do. Also, never rely on a single source of information. If you want to evaluate a person, what he says obviously is not necessarily valid, so you can't trust him. Many of them, they just flatly lie or kind of undermine their behavior. Also, so if you rely on one single source, you increase the likelihood that assessment error will happen. So use as many information resources as you can. Also, never use only one single instrument. You can't use only one of these instruments that we will go through for doing your assessment. It can't, because you will see later on throughout your career that even though these instruments intend to measure the same thing, the same risk factor, but sometimes they come with different results. Now, it is your job to investigate further and explain that difference. Why are these different from each other? So never rely on one single things. Again, these are gonna be increasing the chance of error. And believe it or not, you will get to these things. You will get to these different results. Remember, it's our ethical obligation to investigate and find out about the truth or what is at least the closest result to the truth that we can have, because you are really dealing with someone's life when you do assessment. If you're going for a SVP commitment, or if you're going for competency to stand trial commitment, for example, or things of this nature, your recommendation may put someone in prison for so many years, as opposed to let the person go for so many years, as opposed to put this person in a psychiatric hospital for so many years. Further, you are risking, if you're not investigating enough, and let's say let someone who is dangerous go, release the community because of your error. Remember, you are jeopardizing the risk of the society. So it is a very serious and difficult job upon psychologists when they do the assessment, and all those ethical issues has to be observed. You need to select the appropriate instruments. You need to check the reliability and validity of the instruments. You need to avoid over-reliance on the instrument. Even though we learn these instruments and we will score this instrument, but remember, at the end of the day, you as a clinician is the one who is supposed to make the final decision, not the test only. Test is only your help, your assistant. You are the one making this decision. Also, no cherry picking when you're interpreting the result. What do I mean by that is, you may, as I said before, you may get different results from different tests. For example, two of the tests might say that this person is highly dangerous. One might say that is not dangerous. This can happen. Why? Because they are not all focusing on shared factors. There are so many factors that may increase the risk that are measured by one instrument, but it's not by the other instrument. For example, age might not be an item in one instrument versus there might be the other instrument, or again other factors that are being measured by each instrument. It might be different, and that's why the result might be different. But it is your job to explain these differences, the reason for differences. I wish I really, honestly, truly wish that we had more time to go through these things in more detail. I could give you more example, but unfortunately, the time is limited, and so I urge you to go to the manuals, to and go to internet, investigate, stay in tune with the what is happening with the risk assessments. Now we have risk assessments almost for everything that you want. I mean, the assessment instruments have been flourishing in the past few decades. Virtually every subpopulation of offenders, we have a test for them. SONAR, which is for sex offenders need assessment rating. PCLR, the psychopathy checklist for Dr. Robert Hare. The LCIR, level of service inventory, revised. The SAVRE, structured assessment for violence risk among youth, for young people. Spousal abuse risk assessment. The Static 99 revised. VRAG revised, violence risk appraisal guide. HCR 20 version 3. Now, some of them, I have kind of written the bold font, because these are the ones that we will review and we will learn how to score them. And we are using it now. By now, I mean these days, we are using it in our profession. Now, how to gather information. This is the order that you should go through. Don't change this order of getting information. First, review every single available to you. Clinical records, legal records, whatever is in the history. First, review them. Then interview the resources, the relevant resources. If you are testing a young man, if you can talk to their parents, to the guardians, to relatives, to schoolmates, co-workers, their boss, whoever that is, you can talk to them. I keep repeating myself, your information, your knowledge is your wealth. So do these things first, gather the information, and lastly, interview the patient. By lastly, I don't mean there's less value. I mean the last thing you do in the order of gaining information is interview. Why? Because if you talk to the person first, he or she may absolutely mislead you at the very first interview. You talk to a sex offenders, and that if you read the history, you see that this guy has had multiple sex offenses. When you talk about, okay, what happened, he's going to ask you, what happened, what sex offense, who, when? I did it, I never know about this, thing of that nature. They are always trying to minimize their crime. They're always to deny their crime. Well, almost always. I remember once I was in court, and I was testifying about a sex offender, and the judge said, or I said something like that, Your Honor, when their lips moves, they're lying. And the judge didn't like it and said, not necessarily, doctor. But they are, most of them, when you talk to them, they minimize their crime. So don't rely on what they say. First, get your information. And also, once you're equipped with information, you know when you start talking to the person, who are you dealing with? He may come up very honest person at the very beginning. I mean, whatever he says maybe matches the information that you have, but it may be the other ways around. So we should know about everything that has happened to this person. And the things you see on the screen: psychosocial history, criminal history, all medical history, and these are all the things that you need to know about the person, but these are very kind of abstract. I try to let you, if you want to make a note of it, on each of them, what you need to have. For example, for psychosocial history, you need to have about the parents, about their marriage status, the relationship, there's availability of the parents when they were growing up, parenting style, whether it was harsh versus kind, the culture of the environment that they were raised. You need to know about the family economic class, family educational level, role of religion in the family, family moves, how many times they moved from places to places. If they were raised in a foster family, you need to know about their childhood, the peer relationship at home, school compliance, school problems. Also, during the adolescence, same about the school compliance and school problems. Dropout, for example, you need to know about their academic advancement. You need to know about employment, sexuality, relationship and married, children and custody. These are all military history, gang history. These are all the information which comes under the domain of psychosocial history. As for the criminal history, you need to know about the juvenile and adult criminal history, current legal status, what it is, sexual and non-sexual criminal history, number of the arrests, prior incarcerations, number of convictions, because the number of arrests versus the number of convictions are different things. DUI history, use of weapon, violation of probation, and so forth. These are all coming under the criminal history. As for the medical history, you need to know about the psychiatric history, about the previous diagnosis, about the symptoms, the onset of the symptoms, about the number of the prior hospitalizations, about the psychotropic medication, what are they taking, what have they taken before, about their medication compliance, are they compliant or they just refuse to take their medication. As for the substance abuse history, again, a whole lot of stuff you need to know about the age at the first use, the type of substances that they are using, frequency of the substances, how often they use, quantity, how much do they use, when was the most recent use, how long they have been sober, if they have, and so forth. Again, I can give you tons of other examples, but due to limitation of our time, I just try to, to give you a taste of it. And then we go to the victims' information. These are very important that when we have the victims' information, these are important for scoring also. This is not just for the general knowledge. It's good to know about all these things, of course, but these informations and some of the information has to be official document needed in order to score the instruments. Those are the requirements of the test. So the victim, you need to know about the victim's gender, victim's age, whether the person have had relationship with the victim before or not, whether the victim has been family members or a stranger, and things of this nature. So I guess these are the examples about these 4 or 5 domains of the information that we need to know for our assessment. Basically, there are four type of assessment. I said about the first three. One, instrument that using the static factors, which were actuarial. Well, here I'm skipping the clinical opinion. That is not used anymore, you know. So instrument that is static, using static factors such as the actuarial, the instrument that using the structured professional judgment, the SPJ, instrument using the dynamic risk factors such as Bombi cognitive scale, cognitive distortion scale. And then here I added another one, is instrument assessing protective factors. We weren't, actually, when I say we, I mean these 2 decades which I worked in the state and the last 2 decades which I worked in Anne Klein, and I know of all other hospitals because I have been doing this for some time now. We weren't using it a very structured protective factors. But a good risk assessment, also we need to include the risk factor, protective factors. So I dug in and I into the research area and I found it one thing which was called SAPROF, and we added that one. I introduced it also to the intern psychologists, and we have been using it ever since. And we will go to learn about that also. So these are the instruments, actuarial. I give you example of each. Actuarial, the first column on the left, are including VRAC, SORAC, and Static 99. VRAC, Violence Risk Assessment Guide. SORAC, Sex Offender Risk Assessment Guide. The Static 99 is called 99 because it came to market in 1999. The second column is a structured professional judgment. It's HCR 20, FAM, which is a risk assessment for female, one of the very few risk assessment that we have in the market for female, and SAPROF, which is again this is not a risk assessment, is a protective factors. Then we have those assessing via dynamic factors with Bombi cognitive distortion rape scale, Bombi cognitive distortion molest scale, Ebel and Becker sexual interest card sort. These are mostly subjective, mostly self-report, and they don't have much of reliability, but they're useful instruments. And even though it's self-report, believe it or not, when I was giving it to the patients, some of them really answered it very honestly. And then assessing via mechanical instruments, polygraph and plethysmograph. Neither of them are accepted in court. I don't know about the plethysmograph, but I do not recommend using it even. First of all, they're expensive, they need expertise. And then like plethysmograph is a process by which they put a rubber around the offender's penis, and then they subject this penis to some visual or audio stimuli of sexual nature of different types. And then by expansion of this rubber around the penis, they realize what kind of sexual interest this person has. So those stimuli are all kind of rough sex, heterosexual, homosexual, and even the interest of the children with children's sex with children, and all kind of normal and I would say abnormal sexual activity, and by expansion of the rubber, which indicates the erection in the person, they try to find out about the sexual interest of this person. But I found it very inhumane and very insulting. I don't think that is an appropriate thing to do. I never used it. in my practice.
I have a question regarding that. I know in previous trainings that was previously that is inhumane and you don't include it. Can you get a little bit more specific with that? Because, you know, these are individuals who have done heinous acts. And so wouldn't it be appropriate to learn more about this?
I'm sorry, before you go on, I have terrible time hearing you. I know that you asked me to go on a little bit more about this, but I couldn't understand the rest of the question. Would you just...
Yeah, I just don't know how you're saying that it's inhumane, yet these people have done heinous acts. So why wouldn't we want to find out more information? I don't understand that.
You don't understand that? Why is it inhumane, you said?
Yes.
Okay, again, because you see, there are ways to find out about someone's let's say sexual interest. I always rather it's just like you want to go to medical things and you need to have a surgery. You try to go with the least invasive approach. You try to go, you know, to take the least invasive approach. You don't need to go to the more aggressive one. Now, the plethysmograph, which is being used, by the way, in few prisons in the United States. I haven't seen, in my 30-some years of practice, I only saw in 2 prisons, one in Massachusetts, and I saw the equipment, you know, the room, but again, it is that's maybe one reason that is not being used. And the other thing is bringing someone, having him to lay down, and then placing a rubber around his penis, and then trying to find out, subject this person to all these kind of visual and audio stimuli of sexual nature. I'm not sure this is the right way to think. So that's my opinion. And also, when I talk to my colleague, I mean, many of them share my opinion that this is very inhumane in the sense that you're subjecting this person to so much of unpleasant condition in order to find out about their sexual interest. And then also the accuracy. I mean, anyway, these are sexual stimuli. We all have sexual interest, and I mean, necessarily, if the guy gets aroused by stimuli A, also he may get aroused by a stimuli C or F or whatever. It is not very clear which one is the main one. So the accuracy of these things are also questionable. Let me just go further and give you another explanation. Dr. Ebel, he's a psychiatrist, I think in West Coast, and he has done a lot of work in assessment and treatment of sex offenders. He developed a system about the sexual interest to measure the sexual interest of the patient. It used to be a big box that they put, the person would go into this box like a boot, and in front of him was a screen, and then this screen would show the different pictures of again a various variety of sexual activities with children, with animals, with all kinds. And then we would tell the person, the subject, that, you know, look at these pictures and as many, you know, as much as you like to, and then once you're done with, go to the next one, go to the next one, go to the next one. Based on the time that this person was pausing on each slide, the machine would give you a report that what is this guy's personal sexual interest. Now, and they would, by the way, they would say that at the very beginning to the subject that why are we doing it? We want to see what's your sexual interest. So In other words, they would give the opportunity to the person that if he wants to fool the machine, they can. Nonetheless, they claim that no one could do it, no one could fool the machine. The problem was, again, that this went to court, and the court stopped using it. They threw it out. It was used in even federal cases, but they just throw it out, not because of what I'm saying, which is inhumane or whatever, because this one was not that bad as plethysmograph, but because the results that were they claim that there are articles after articles that shows the validity of this assessment process, but all those research were done by Dr. Ebel and his own institution. He never released his data for independent confirmation of the result, and he refused to do it, and as a result, they threw it away. I don't know how much I could answer your question, but basically it's an opinion that once you have a less humiliating approach, I would always take that one. Okay, what you see on the screen right now is the suggested risk instruments that I am recommending for violence for men, sexual violence for men, and violence for women. I believe that most of the psychiatric hospitals in New Jersey are using these tests for the purpose of the assessment that they do. Now, do not necessarily limit your assessment to these instruments, but these are the essential ones. At that time, you might find it necessary to adopt some other instrument as well. You may want to, for example, do a personality test also. You may want to do an intelligence test also, or any kind of other test. More than welcome to do it, and the more, again, information you have, the better assessment you're going to have. But these are the basic ones. For men, we use HCR20, the last version. We use VRAG, and we use SAPROF. SAPROF, again, we see that asterisk because it is protective, it's made the factors, not the risk factors. For the sexual violence, again, the HCR20 and SAPROF are there, and VRAG, but again, we are adding static 99R. This is a 10-item instrument which is used only for sex offenders. And then SORAG, the SORAG is sex offender risk, but once they revise the VRAG, they claim that the VRAG also can give you an idea about the risk of sex offender as well. So you don't need to do the SORAG separately. Also for women, we are using the HCR20V3, version 3, even though the validity of the HCR20 for female is not as good as for men. And that is why the FAM came into the market. They are so interconnected, HCR20 and FAM, female assessment annual manual, and the SAPROF. So you see the SAPROF is shared between all three. HCR20 is shared for all three. And VRAG is not for female, only for male. And the FAM, of course, only for female. My intention is to go through all these instruments during the 2 days. Hopefully we can do it. If not, I may have to add another half a day to the presentation, so for those who are interested to go through. So here we go. Part 1, we start going to HCR20. Is there any questions so far? Okay. Who can do this HCR20? What are the user's qualifications? 2 things is necessary. One is the ability to conduct individual assessment, and I believe all of us so far through our education, we have learned quite enough of how to do a test, how to administer a test, how to observe the condition, what type of test we should use, of course, and all that kind of stuff. But I always urge you to stay in touch with the study of violence, because they're, day by day, these are being enhanced. The tests are being enhanced. They're being revised. As time goes on, they found out about the deficiencies of these instruments. They correct it. They change the items. They bring this new stuff in. So stay in touch with this study. I mean, I think we have an obligation to stay in touch with the latest of all aspects of our profession. But for risk assessment, for sure, you need to be informed of the changes. Many of the instruments that we used to use is obsolete now. Americans had an instrument, it's called MNSOS, Minnesota Sex Offender, which has been obsolete. The court threw it away. We are not using it anymore. But then there were some others, the new ones that we are using. The new versions we are using, the old versions are obsolete. So stay in touch with the latest information. When coding the instrument, use the manual. I can tell you that during my career lifetime, I have done hundreds of assessments. Because of the nature of my job, which was the sex offenders assessment and treatment, everybody who came into for the last 30 years, we did the PCLR, we did the static 99, we did all that. Still, I do not consider myself as an expert. I do not consider myself to be competent enough to start doing the assessment and scoring this instrument without the manual. There are so many little things that you need to observe when you score this instrument that it's impossible to remember all of it. You have to have this manual in front of you. Don't leave, don't go for assessment without the manual. The manual has to be next to you. By the way, does anyone remember this guy? This guy used to be, I guess he used to be commercializing for American Express, and the slogan was "Don't leave home without it." So I use this one to say, don't do assessment without your manual. Now, the site on the screen is where you can go to gain competency and build expertise for different kind of tests. But the concept really is a place to go. And Pat is the director, Patricia Ferguson, and so you can go to that, click on this, select and register for Foundation of Violence Risk Assessment and Management. This is for HCR20. Kevin Douglas and I think Stephen Hart is the one teaching it in this course, but it's going to cost you about $1,500. It's 40 hours and 40 CE. So you realize that when I say each of these instruments takes days, that is, for example, one example. And I have done a few of them only for HCR20 and others. So this is the manual. I don't know who has the manual, but this is the manual that you need to have in front of you. All the information is there. The one in the back or the worksheet. I hope that you have the worksheet in your in front of you, because I don't know. I asked Dr. Waldron to make sure that you have the worksheet. Does anyone has it, by the way? Anyone has the worksheet? No one? Can someone answer? Hello?
Yes, yes.
Yeah.
Yeah, we do have access to the manuals.
Okay, great. All right. So because that's just that's a very helpful tool. Okay, and these are the, by the way, the scoring sheets. I don't know whether you have that one also or not. They're very much similar. The one on the right-hand side is the least, I mean, the most concentrated one. That's the one that I used to use. On the left-hand side is the same thing, but is more expanded. I mean, each item is being scored for 3 segments of lifetime. They scored for as a child, 12 years and under, as an adolescent, between 13 to 17 years, and thereafter. On the right hand side was not the one. You can use either one. You can use this one. Of course, I recommend you to use the worksheet that it is, because it's the most first, because it gives you all the information, and then transfer those information and the findings into this one. And as you see, the response is no, probably, yes, for each item. Violence, for example, history of violence, either is no, is probably, is yes, or for whatever reason you can omit the the item. It was originally started in 1995. We weren't using it that often because it was mostly the beginning of it. It was mostly kind of for research and things. But in 1997, I believe the second version came, and this was the first 2 versions was only for the assessment purposes. And then the final version came in the market in 2013, and that was like a revolution. The whole thing changed, because what was proposed was that what is the point of assessment? The point of assessment is really, the goal of assessment is to the management of the risk. So what is good about finding out that someone is dangerous if you don't do anything about it? So the whole criteria changed. It became a much more sophisticated instrument, and it became, I mean, everybody started using it. We needed training, and so it was kind of difficult at the beginning for us, but eventually we got into it, and nowadays I think almost all psychiatric hospitals in New Jersey, at least, they're using it. SCR20 includes variable from the past, from the current, and also present the future considerations for the management. It is intended to use with men and women. As I said before, the woman reliability is not as great as for men. It can be used for assessment and management of the violence risk within correctional, civil commitment, forensic, or general psychiatric setting. Okay, so we are they're using it in legal and clinical, as I said, for admission purpose, for monitoring, to see whether there has been any changes, to classification, and for so many other reasons they're using it. Okay, let's pause for 10 minutes and a break, and then we will be back. It is 10:08. What about if we come back at 10:18? Please make sure that be here at 8:13. I don't want anyone to miss these slides. Thank you. See you soon. Okay, is everyone back?
Yes.
Okay, great. And so you see the slide. I hope I haven't changed anything. All right, so let's go to HCR20 V3, the version 3, and this is in today's market and profession. Our profession, at least in state of New Jersey, I guess all psychiatric hospitals are using it. Is also, I see that many of my colleagues in private practice, they use it. It is a well-established instrument, and it carries a very good reliability and validity. It is not being challenged in court by anyone. I mean, there are always, when you go to court to testify, you may get the opposing view from the attorney of the other aisle, but basically, we have always won the argument if we have been challenged by anyone. So as you see, there are 20 items in this instrument. Out of those 20, 10 items are historical items, 5 are clinical items, and 5 of risk management items. You remember when I was talking about actuarial, I said the static factors, the historical factors are more reliable factors. And even in construction of this HCR20, you see that out of 20 questions, 10 of them are historical. Historical variables or the static variables, they are history, they're there. They're not going to be changed. So we go through each item, and I try to give you some examples. I cannot go through too much of detail because it takes forever. You saw the address which I posted it. That is 80 hours only of or 40 hours of what they have different courses, 80 hours, 40 hours. So it takes longer. This is a very brief review. All right. There are historical items, 10 items: violence, history of violence, other antisocial behaviors, relationships, employment, substance abuse, major mental disorders, personality disorder, traumatic experiences, violent attitudes, and finally, treatment supervision. Whether there is a problem, there's a history of problem with any of these things, these variables, we score it. I go through each item later on briefly. The second part of are the clinical factors, which are the insight, violent ideation or intent, symptoms of major mental illness, instability, and treatment or supervision response. These are the clinical items. These are what is we are measuring, which are right now is going on with the patient. And finally, the future risk management factors. We are scoring professional services and plans that are out there, the living situation, the personal support, the treatment or supervision response, and the stress or coping. You see that some of these items are shared in all three aspects of this test. For the last question, the last items on each: treatment supervision. You see it's on historical factors, on the clinical factors, again, treatment or supervision response, on risk management factors. R4 is treatment or supervision response. They are similar, but the scoring might be different because they're happening in different times. On the first one, whether it has been a problem, there is a history of problem before. On the clinical factor, whether this problem is right now, and on future, whether this is going to be a problem later on. And some of this, by the way, we may have to score in both the same in both section. We will get to it, and I explain it to you. How does that happen? But these are all pending on the timeline. What do we mean by history? What do we mean by clinical? What is timeline? I explain it to you. So let's go to administration process. Basically, there are 3 steps in scoring the HCR20. First thing is just identifying the facts, meaning that we need to have the information, we need to know this, and also we need to score the presence of the risk. Are they there, partially, fully, yes, no, whatever. And then after finding this information, we go to make sense of this information, put these things together and make a sense of our findings, and then finally we take an action. This is the part that the last 2 part was the one which was added to the test in the last version, the version 3, making sense and taking actions. Now, the first identifying factors has 2 steps, making meaning is 3 steps, and taking action is also 2 steps. I wouldn't occupy myself with these numbers and columns and numbers of things. Just on the right-hand side, this is what we're going to do in sequence: gathering information. We score whether these risk factors are for each section is there or not. We know the relevance of these factors for each person, then formulation, scenario, management recommendations, and final options. We need to go through all these steps. Step 1, gathering information. I told you what kind of information do we need before. Every kind. I went through the list of maybe 100 items that we need to have information about it. So review the record related to the context of the evaluation, and then obtain information, as I said, from collateral sources, including the family, friends, neighbors, professionals that work with him, whoever. Review the criminal justice record. Those are very important. Some of them we need to have the official records. Interview with the, and also observe the evaluee. I used to, when I was doing my evaluation, I used to go around and see how this person is functioning when he's in rehab, when he's in a day room, or how does he interact with the staff, with peers, and so on. And then also the history of violence and whether violence ideation, and if so, when, what, who, why, and all those W's are to be answered. And chronicity, the age, the frequency, the diversity, the severity, and escalation things. All of this information we need to have. So this is the very first step of our evaluation process. Then we go to the coding of the history. Now, I hope again you have those coding sheets in your possession. If I send it to Dr. Walden to distribute to you. So if you have that one, have it in front of you. So take a look at it. That the historical factors reflect the features of the evaluee's history of psychological adjustment. So it's good to start, when you want to score, start by asking, has it been a history of problem with then the items? Has it been, for example, a history of problem with violence? Has it been a history of problem with, say, personality disorder? So start with this question when you're doing it. Has it been a history of problem with an item? Now, what is important is the timeline for each of these three sections. What is the timeline for historical factor? The timeline for historical factor is lifetime. Has the evaluee ever had problem with respect to this risk factor for each item? Even if the only event or occurrence were within the past few days or a couple of weeks ago. And which by the way, when that's the case, it also be scored in clinical factor as well, because the timeline for clinical factor is the last few weeks. So one thing to remember is the lifetime when you are scoring. The lifetime of historical factor has been, I'm sorry, the timeline I meant to say. The timeline of historical factor has been lifetime. All right, the coding is, as you see, yes, Y for yes, P for partially, no for no is not existence or not information or not applicable. I will give you some example of indicators for each of these variables. There are pages and pages of explanation in the manual for each variable, so you need to go through it and study it well. But this is just a brief review. The violence, whether it's yes, partially, or no, it's a judgment. It's a judgment based on reviewing the history. It's a judgment call. You have to see whether fights, he has been a history of fighting in which the person was the instigator or the primary aggressor, or this violence has occurred in multiple contexts, school, home, community, institution, so forth. Whether the violence has resulted in serious physical harm to victim, whether this violence has been toward families, close friends, or only stranger, staff, and others. Again, tons of examples, but let's stop right here. Go to the next one. Whether there has been a history of problem with other antisocial behaviors. The examples has whether this person has acted or attempted or planned motivated that are motivated by financial or material gain or let's say sexual gratification. Or other example, has it been any illegal possession, manufacturing, importation, or trafficking of substance abuse? This is another indication. Whether it has been gang activity, whether it has been these activities started in early age, I would say before the puberty. Enough of that. I go to the next one, the relationship, the indicator. These are the serious problem establishing and having serious problem with establishing and maintaining a stable personal relationship, whether intimate or non-intimate, it doesn't matter. That result in a lack of positive social and emotional support. Also, a lack of relationship is noteworthy, even if the person is institutionalized. In other words, you can see your patient in the institution, in the hospital. Is he communicating with others? Does he have any friend? Has he has a buddy or someone, even with the staff or with patients or with peers? You can observe that one. Next one is the problem, history of the problem with employment. What you need to look for is a serious problem seeking and maintaining or abiding by the rules of employment. Long or frequent periods of unemployment is another indicator. Having constant financial difficulties in this area, inability to provide for one's own basic needs, housing, food is another. Now, there are exceptions. This item will be irrelevant in few cases, and we can omit it. Example is, let's say, a 17-year-old who, having just left the school and has had little or no chance to establish work history. So obviously this is going to be biased for him. So we're going to omit this question for that person. Next is the history of problems with substance abuse. Now, of course, we know what is the substance. Is anything consumed by, ingested by, or administered to a person primarily for its intoxicating or performance enhancing, mood altering effect, rather than for its nutritional value. The indicator of for scoring yes, partially no, that has it ever been in this person has had history of using it. The use started in adolescence or childhood even. It has spanned during multiple developmental stages. Multiple substances use, heavy use, chronic use, use in controlled setting, even in prison, in hospital, involvement in drug trade, distribution, that kind of stuff. So, moving on, major mental disorder. A history of major mental disorders characterized by disturbances of cognition, or affect. Things that we're watching. A psychiatric disorder, major mood disorder, or other major mental disorder. These are what we're looking for. The psychiatric disorder, we're looking for any acute positive symptoms, such as hallucinations, delusions, agitations, irritability, or hostility during this psychiatric episode when it occurs. So that's one indication. The other indications are for the mood disorder, the affective. These are things, symptoms like depressed mood, cycling mood, psychomotor agitation or retardation. And the third one part is the other major mental disorder, which was characterized by symptoms reflecting gross impairment of intellectual, cognitive, or social interpersonal functioning of the person. The only thing is, I must say here, which when you are doing this major mental disorder, personality disorder is not coded under this item. Personality disorder is going to be coded under the next item, which is H7. Okay, so the problem here must be chronic and pervasive in nature, as opposed to some episodic or situational disturbances. It has to be ongoing. Again, here we are considering separately personality disorder of the antisocial type, which is variously referred to as antisocial, psychopathic, and disocial personality disorder, and all other personality disorder, which include antisocials, all other one, which exclude is the one that I named. Indicator of the antisocial and psychotic are like domination, antagonistic, hostile, having a sense of being unique, entitlement, deceitful. These are the one which tells you whether this person has the personality disorder of the antisocial type. The other indication for other personality disorder are instability, disorganized, self-harm behaviors, interpersonally anxious, dependent or ambivalent, and emotionally intense, labile, anxious or distressed. And sense of self among these people is very weak. And if they have the diagnosis, by the way, which is then it gives you a clear yes, those diagnoses must be based on either DSM-5 or ICD-10, I think now. Also, there is an instrument called PCLR, psychopathy checklist, that gives you a good indication, but it's a very, very time-consuming, difficult test to administer. By itself is a course of few days to learn about PCLR. We used to use, by the way, the PCLR score was before included in many. It was an item in many of these instruments that we use. But nowadays, and the later version, one by one, they took it off the test. So we are not using it anymore. Now, the history of problem with traumatic experience. Well, what are the indicators? Parental, primarily caregiver child abuse, either sexual, psychological, emotional, or physical, or neglect during the childhood, 12 years and under, or during adolescence, from 13 years to 17 years. Non-parental child abuse by family members, by other people, sexual, psychological, emotional, or physical, again during childhood, adolescence, and later. Or even witnessing or being exposed to family violence, or even violence toward the non-family, non-parental loved ones. I wonder that maybe I should give you a little bit more example of this traumatic experience. The adverse child rearing experience also, the parenting style has been coercive or overly harsh, unstable household, parental non-violent criminality, and all those kind of stuff. Violent attitudes. Violent attitudes and violent beliefs, values, or thoughts, such as the believing that the use of violent behavior is justified to meet personal or material goals. A beneficiary end justifies the mean to these people. Present during childhood or adolescence. Violent attitude span over developmental periods from youth to adolescence and later on. Justification of violence. When you talk to these people, they try to justify their violence to obtain financial or material benefit. They minimize or deny their violence. Constant involvement in criminal organization. So you evaluate all these things, review all this information, and then make a judgment whether this person has a violent attitude, partially or no. And finally, the last question of historical, whether there has been a history of problem with treatment or supervision response. If you are having the patient in your place of the work, like if you work in a psychiatric hospital, this is not that difficult to find out about it, but they usually have negative, hostile, pessimistic, uncooperative attitude toward the treatment plan that you make for them. They fail to attend the treatment or supervision sessions. They are very insincere in their participation. They're very superficial. Or outside, for example, if they need to go to court, they don't report to court, or even escape from institution or prison even, or hospital. We have had all these cases. So again, in summary, check the history of this person's life, and on each of these 10 items, there are tons of examples and guidance in the manual that you can use in order to score these items, as well as the other items. Well, I mean, this is also all other consideration, history. If you see anything which is not the history which is notable and has to be mentioned in your report and is not included in these 10 items, you're more than welcome to add that factors. So then we move on to the next. We finished H, we are moving to C, clinical factors. They reflect certain features of the evaluee's present psychological adjustment. Now, what is the time frame for clinical items? Is the recent past. What has happened a few weeks to several months within the last 6 months, or not longer than that. That didn't become history then, preceding the evaluation. So whatever has happened from a couple of weeks to a few months preceding the evaluation is considered to be the clinical events, clinical factors in this time period. And so let me give the same. I give you some example. The recent problem, what there has been recent problem with insight. Has it been any change in his insight during the last few weeks up to last few months? The current problem with lack of awareness or understanding or appreciation of one's violence behavior. It is encouraged to consider 3 aspects of problem with insight. Again, the mental disorder, the violence risk, and need for treatment. These 3, has it been any changes in insight toward any of these 3 factors? Moving on, violence ideation or intent. What are the indicators of this? Frequent or persistent thoughts of harming others that are detailed, realistic, and feasible. So to keep talking what I'm going to do this in a very detailed to who, in very explicit term. Recent escalation in violent behavior and ideation. Or a person who takes pleasure or satisfaction in harming others, or even observing others being harmed. Even he's not a participant, an active participant, he really enjoys watching it. And so these are the indication for the violence ideation. Now, the symptoms of major mental illness. Again, these are the recent problems. Obviously, the person, if you see a person in psychiatric hospital, there is a mental disorder. There's a reason for it being there. And but whether there recently has been any changes. Just like H6 historical checks, which was a history of problem with a major mental disorder, just like that, we recommend that evaluators consider symptoms of the following 3 types of major mental disorder: psychiatric disorder, major mood disorder, and other major or mental disorder. I gave you an example of each, so we're not going to go through it again. A, B, and C were already discussed on the history part. Moving on to instability, it is the current serious problems maintaining a stable adjustment with respect to A, affective, B, behavioral, and C, cognitive functioning. So problem in any of these 3 aspects, and I give you some indication for each. For affective instability, what we are looking at is the hopelessness or sadness, serious distress or anxiousness, serious irritability or anger. Mood is very labile or changing rapidly from one emotional state to another emotional state. Hair trigger, temper, so forth. As for the behavioral instability, what are we looking for is restless or hyperactive, like pacing, for example, sudden outburst or anger or aggression, acting in an impulsive or irresponsible manner without considering alternatives to or without considering the consequence of the actions. acting abruptly in a reckless, disruptive, aggressive, or even self-destruction manner, which, by the way, may expose self or others to undue risk. And finally, the indicator of cognitive instability is the views self as being bad or evil, no clear or consistent sense of self, distractible, that is, can't focus attention or maintain concentration, quick to judge or blame others, gives little forethought to decisions that makes. Oh, of course, there are a whole bunch of other examples. Finally, the last one on the clinical factor. Has it been a recent problem with treatment or supervision? Well, these are the current problems in accessing, attending, being compliant with, or benefiting from mental health, forensic, or correctional interventions that we are offered to the patient, or management strategies that we offer. They're all designed to reduce risk for recidivism or violent, but the person is not responding very well. And we remember that in here we consider both the compliance and the responsiveness. I mean, sometimes they do comply with some medication, but the response is not good. So it's on our part to evaluate and consider changes. So this is for coding the clinical factors. And again, if there is any other factors which is happening recently, by all means, please include in your report. Okay, now we are moving to the last part of the scoring, which is the risk management items. Before we start coding the risk management items, make sure to indicate the context of this assessment. There is a box in your answering sheet, in the scoring sheet, coding sheet, which says in or out. It is important to clarify the context by clicking those box. If you are doing the risk management plan for in-house or in the institution, there is a different story than when you are doing a risk management plan for outside of the institution, simply because the level of observation, available resources, professionalism, and all these are much better supervision, or much better and more enhanced inside the institution, as opposed to when the person is outside, without many of these things being available. So that's the first. Now let's say again, as we said, risk management factors reflect features of the evaluee's anticipated psychological adjustment in the future. Now, what is the time frame? Of course, is when the person either leaves the hospital or is the very near future, a few weeks to several months. So this plan is for a few weeks to several months, between about 1 or 2 months and about 12 months, immediately after the evaluation. So this evaluation is happening right now. The plan that you are making has to be good enough based on what is happening to this person, based on the next, based on his need for the next 2 months, 3 months, or even up to 1 month, or even up to 1 year. I'm sorry. So that's a time frame. We have 5 factors here. The professional services and plan is is factor number one. What are available for this person? The problems with development of plans that make appropriate use of professional services or programs such as healthcare, social services, educational services, vocational services, criminal justice programs designed to manage violence risk through either monitoring, supervision, or assessment and treatment, and so on. All these things are considered in this are considered things. It has to be considered in this factor. A plan for professional services, for example, may be deemed inadequate when they have not been made or communicated to the others. So if the person is going out on this plan has to be really communicated with the people in charge outside, the social workers, or if they have to go to a rehabilitation plan, the rehabilitation place, it has to be communicated with the people responsible for that program, so forth. When the plan is unclear or lacking in detail, there's a difference. For example, when patient is in a hospital, we know exactly what we're doing, but not necessarily people outside, or when person is transferred in the future, they are not as familiar with this person and how does this person respond to the treatment plans as we are. So it has to be detailed and explained to them. And also make sure that the professionals out there are appropriate professionals. Make sure identify the needs of this person for certain services. If he's a sex offender and he needs to continue to go to weekly or bi-weekly classes of sex offender treatment, then make sure that those services are available. If this person needs to go to rehabilitation for, let's say, substance abuse, make sure that it is being set up for. So the availability of these services that person needs is the main and most important thing for this patient to go. Whether there's going to be problem with living situation, like problems with an either problems in the institution or in the community. Examples are the domains of housing, employment, affiliations, neighborhood, exposure to risk-enhancing factors such as weapons or substances, whether there are conditions that could destabilize the person's risk-relevant functioning, like psychiatric, emotional, cognitive, or behavioral. The other indicators are residence is unstable or uncertain, and the patient is not sure in which room or which house he will be sleeping or living. The patient is, the residence, the place is chaotic. There are too many people in that house. People move frequently in and out. There are conflicts among the people inside of the house. The place does not offer opportunities for positive social engagement because the environment is negative. Or the patient has inadequate employment or finances out there. All these resources that enhances the living situation has to be in place. Then we have the future the problems. We may have future problems with personal support. This item reflects future problems related to personal support and making arrangements that incorporate personal support. What are personal support is day-to-day interpersonal contact with members of the person's social network that is expected to manage violence risk by facilitating the person's psychological and social adjustment. If there is no real social network out there, that's a risk, that increases the risk. The social network could include people who are likely to have a negative impact on the person's psychological adjustment. So if it goes to the wrong place and associated with the wrong people, obviously it's going to be part of the social network, but this is a destructive social network. Moving on, problems with the treatment of supervision. And as I said before, this question comes in all 3 sections. These are problems in accessing, attending, being compliant with, or benefiting from mental health, forensic or correctional intervention, or management strategies designed to reduce risk for recidivism or violence. It is like in clinical item number 5, although pertains to the future in this section. In clinical, it was for the time being, this is for the future. Also, as for clinical number 5, we suggest that the consideration should be for compliance and responsiveness both. Compliance has to do with the patient. If he's going to obey by the rules, if he's going to listen to the treatment, if he's going to be medication compliant, that's one thing. But then if this is there but he's not responding, let's say, to medication, then that's another issue. So both of these issues has to be considered. And finally comes stress of coping. Living circumstances sometimes is likely to be very stressful. Anyway, change is stressful. If they go from somewhere to other place, change by itself is stressful. Or likely to experience very stressful life events such as relationship breakup, death of the family, may face death of a member of the family or friends. It may have faced financial or employment difficulties. Some of these people, they have uncertain immigration status. I mean, they might face deportation. They don't have permission to stay. We have faced many of these things. So the social workers should work to find a way or solution, solve this problem. And also, many of them have difficulty coping even with minor or very common frustration and problems. So these are all the problems that may happen in the coding. And again, if there is any other consideration for the future, and I usually, when I write my report, beside these 5 factors, there are many other factors that it may be there, which is not included, and it has to be included, because as I said, maybe this is the most important part of this evaluation, because as I said before, the whole changes, the main purpose of the changes of the HCR20 was to managing this risk. And if the management plan is not correct, then, we have wasted our time. All right. Now that we gathered the information and we kind of scored or coded the existence of the risk factors, we found out who they are, what they are. Now we're going to the step 3 of which is the relevance of the risk factors. Individual relevance of risk factors are the bridge between the nomenclatic and idiographic level of analysis. It's bridge between the general universality and the person, a specific person kind of characteristics. This quote, I found it very interesting. Every man is in certain respect like all other mans, and every man is like some other man, and every man is like no other man. So yes, we all get angry when something happens which is anger producing. We all get angry, but then we are not getting angry exactly like each other. Some of our reactions are not like similar, very much different. So yes, if the person has a history of anger, that's one thing. But what are the specific things that he is sensitive to? On what situation he responds differently, intensely? That is what we need to know. The risk factors identified as relevant are important consideration when we are making plan about monitoring, when we are making the treatment plan, when we are assessing for the supervision, for the victim safety plan, and all others. What is a risk factors is defined to be relevant? When that risk factor is a material contribution during the past violence episodes, and therefore it is likely to influence the person's decision to act in the same violent manner in the future. That is a relevant factor. Or a factor that impairs the individual's ability to choose a non-violent problem solving or to manage his anger in order to mitigate the risk of violence. This is a factor which is relevant. Or it is likely to hinder or decrease the effectiveness of various strategies to prevent future violence. We have made the treatment plan, we have made it, but we see that he is not responding to some of them the way it should be. So these are some of the relevance of the risk factor for the individual. Now, how do we determine relevance of the risk factor in any given case? But there's not a simple way that I can say, okay, use this one. There's not a test objectively to measure relevance, but there are some keys which can help. Careful examination of the past violence. Conducting functional analysis to identify the function or purpose the violence serves for that individual. Why is he committing that individual? Why is he gaining? What is he gaining by that? The most important criteria for judging the relevance of factor is their functional relation to the violence, what they gain, which they can be motivate their decision, makes this violence attractive to them. They can disinhibit decision. Some factors make the person less likely to be influenced by the potential consequences, negative consequences, or destabilize decision, disturb the evaluator's ability to monitor and control himself. Let's go through some of the example here. I mean, you can see on the screen the functionality of these relevance factors, motivators factors, which increase perceived rewards. Justice, I do the because I have revenge, retribution, gain profit, accusation, release of emotion, getting even, defense or protection status. People who are bullying and in prison, everyone is scared of them and they have their own status. Dominance, control, these are all motivating factors. Now there are disinhibitors, lack of guilt, lack of empathy, lack of insight, negative attitude and self-concept, alcohol intoxication, and on and on and on. These are the disinhibitors, decrease the perceived cost. And finally, there are the stabilizers. These stabilizers disturb careful decision making, disturb perception, impulsive, intrusive, impaired memory, chronic drug abuse, acute mental disorder. All of this kind of destabilize the person. So these are the factors, the three that we need to be careful about it. We need to be observant. How do we now quote the relevance of HCR2? It is not like yes, no, maybe. It is either high, means that that factor is relevant to the development of risk management strategies. Remember that we want the relevance because it is important for risk management. So whether they are high, highly relevant, moderately relevant, the factor is possibly or partially relevant to the development of risk management strategies. And then is low relevance. The factor is not relevant to the development of risk management strategy. And we omit if there is no reliable information to make a judgment. Remember, I said that this is all a judgment or call, but then once you want to make that call, you need to be equipped with information. After we find out about the relevance and we score them, then we go to the next step, which is the risk formulation. To prevent violence, it is necessary for us to understand the violence. Formulation synthesizes diverse information about the individual in order to provide a concise understanding about the nature and the etiology of the person's problem. So a complex things becomes a simply understood thing. The most important task of formulation is to have a solid understanding of why this person has acted the way he has in a violent manner in the past, and why they may do so in the future. Such an understanding is necessary, obviously, to manage the violence. Now, if you go to, you see that the asterisk in the bottom of the screen, it says CHCR20 worksheet. If you have that 5-page worksheet, it's not 5 pages, it's more than that, but there are lots of information for each of these procedures. For example, for risk formulation, it guides you what to look for, what to find out, what you need to find out, or for the risk formulation. Once you do that, we want to see, is it possible to identify the risk factors that may function as a root cause of the problem? Is it possible to construct a hierarchy of the relevance risk? Which are the most important ones? Which are the less important ones? Is it possible to identify the predisposing, precipitating, perpetuating, and even identify the protective factors? Again, to see what function does violence serve. Identify theoretically causal roles for risk factors, those motivators, disinhibitors, and destabilizers. Motivator factors Again, I said it before, makes an attractive violence, this makes the violence attractive. Example, threat of violence often rewarded in institution environment. Disinhibitors, factors, violence, why not? Alcohol, drug, antisocial beliefs, and the stabilizer constrain a person's ability to pay attention or control decision making. Mental illness, trauma, sequences, so forth. Formulation of risk formulation should be theory driven, evaluated. You guys should be familiar with and base formulation in theoretical model that have good support. Now, there is no way for me to go through this formulation theories. There are tons of them, and you need to kind of become familiar. I gave you some example here, like general personality and cognitive social learning. We call it GPCSL. You can use that approach. The good life models, another approach, decision theory framework, the 4P, predisposition, participating, and also the root cause analysis. And even the book says, even though at the beginning the manual says that use the one that has been well established, but it also says that you don't necessarily have to follow one of these. You can, whatever approach or other models that you choose is okay, as far as you're able to make this formulation. After formulation, we go to the next step. And again, there is an asterisk there, meaning that in your booklet, in your scoring worksheet, there are guidelines that runs you through how to do it. Okay, what we do in the risk scenario, it is used to make the final bridge to risk management, like the practicing, like exercising. Risk scenario represent future-oriented formulation. It's for the future. What has happened has happened. This is not planned for the future. What might a person do in the future? And why that person is doing it? What are we trying to prevent? What exactly is that we are worried that this person might do, which should not, so we can stop it? Each scenario is a story about violence the person might commit. Bear in mind that scenario is not a prediction about what will happen necessarily. Rather, it is a projection about what could happen. So if this person who's going to be released from this hospital to home or to supervised home or whatever, what may happen to him violence-wise? So the way we do is we start by doing 3 different scenarios. One scenario, the first one, is the scenario in which the person commits violence similar to the most recent act of violence. This is called flat trajectory. So if exactly like that, then consider a better case or a more optimistic scenario in which the trajectory decreases. Is not gonna do, of course, the person commit a less serious act. It's not gonna be as bad as it was here. And finally, the third one, consider a worst case of or doom scenario in which the trajectory increases and the person commits a more serious, perhaps even life-threatening act of violence. So 3 scenarios, and then for each scenario, we determine the risk, and we determine the actions that we need to take in order to mitigate that risk. All right, in this, to make this scenario, we have to find answer to the following 5 questions. These 5 questions are listed again in your scoring sheet. Question number 1, what would be the nature of the violence? What kind of violence is the individual likely to commit? Who are the likely victims? These are all in question number 1. What is the likely motivation? What is the individual trying to achieve? The next question, the severity of the violence. What might be the physical harm to victims? What might be the psychological harm to victims? Is it possible that the violence might escalate to serious or even life-threatening violence? There are, other questions as well. Next question, imminence of the violence. How soon might the person engage in violence? Are there any warning signs that might signal that the risk is increasing or it is imminent? Next question, frequency or duration of the violence. How often might the violence occur? Once, a few times, many times? How often? Is the risk chronic or acute? That is, limited to or concentrated in a specific period of time, or is it longer? And finally, the likelihood of violence. How frequent or common is this type of violence? Based on the history of this individual's violence, how likely is that this type of violence will occur? So we need to answer all these questions when we are making this scenario. And then in accordance with the answers that we have, we are making the plan to prevent and mitigate this violence. Then we go to step number 6, risk management strategies. So now, based on the consideration of the presence of the risk, we know what are the risk factors, what risk factors exist. We find out about the relevance, what items are more relevant for the risk. We made a risk formulation, as well as the scenarios during the first 5 steps. Now we recommend risk management strategies. Now again, we discussed it before, but it is so important to clarify the context of the risk assessment, because this is put in or out in your worksheet, because the plan is going to be quite different when you're making it for the outside living, outpatient, as opposed to inpatient. You have a lot of supervision and control when the patient is committed, but when it's outside, you have much less control over it. So you have to, sometimes you have to make for both. I mean, your recommendation, because there are times that the patients are being discharged, we are not quite sure that where are they going to be ending up eventually. So in these cases, I always make a plan for both cases. If the person is going to be inpatient, these are the things need to be done. If he's going to be living outside, these are things to be done. If it's going to be in half house, these steps are to be taken. Okay, think about risk management in terms of 4 basic activities. 4 things need to be included in your risk management. Number 1, monitoring or surveillance. Okay, so there you can evaluate changes in risk over the time, what is happening. Number 2 is a treatment, provision of rehabilitative services. What are available? What are recommended? Supervision and control, restriction of individuals' right of freedom, institutionalization. All of these are important factors. And finally, the victim safety planning. Not the predators, the victim safety planning. Target hardening, improving a potential victim's dynamic, social environment, and also static, like physical environment, security resources. So, Mr. And then conclusionally, your final opinion, a summary judgment in a clear, simple manners that facilitate appropriate action for risk of future violence, whether it's low, moderate, or high, for risk of serious physical harm, whether it's low, moderate, high, and imminence of violence, low, moderate, or high, and case review date or reassessment. You also put that in your, that this person need to be reassessed, let's say on this date. By the way, for the high risk individuals, the reassessment has to be much sooner. You can't say a year from now for a high risk individual. I would say in a couple of months at most, or even a month. If other indicated again, then we can include that one. Now, I asked Dr. Waldron to send you a case study about Mr. Jones. He's a 20-year-old man admitting in a forensic. I want to see if you had a chance to review it, and did you, what do you think about these things? I will say that I give you, how much time do we have now? Not much, it's about 11:30. What about we stop here? I want you to study that risk, the case study, and based on this, what we went through today so far, make your judgment about the level of risk of this person. And when we come back, we will discuss about it and then move on from there. Is this okay with all? Yes, no?
It should be perfectly fine.
Okay, so when we come back, we're gonna review this, and then we will go to the part 2, which is FAM. Dr. Waldron, I wonder if you are there.
I'm here.
Okay, what time should we go back? Is
1:15 would be our start time.
1:15. All right, so see you everybody at 1:15. Thank you. Have a nice lunch.